Well, good afternoon, everyone. Welcome to this special event, and to everybody joining by internet for live streaming, a special welcome to everybody online. It's my pleasure to introduce our speaker this afternoon, Professor Margaret Barry, and she's going to be giving us a talk on innovative approaches to promoting population mental health and well-being. Who needs to be engaged for effective action? This presentation has been made possible by a Dobbin Atlantic Scholarship from the Ireland-Canada University Foundation with support from the Irish government. I'm going to offer just a quick bio on Professor Margaret Barry before we start. So Margaret Barry, PhD, holds the established chair in health promotion and public health at the National University of Ireland, Galway, where she is the head of the World Health Organization Collaborating Center for Health Promotion Research. Dr. Barry will be a visiting professor at the National Collaborating Center for the Determinants of Health here at St. FX University from May 29th till June 9th, and her stay is supported by the Dobbin Atlantic Scholarship. Professor Barry has published widely in mental health promotion and works closely with policymakers and practitioners on the development, implementation, and evaluation of mental health promotion interventions and policies at national and international levels. Elected as Global Vice President for Capacity Building, Education, and Training by the International Union for Health Promotion and Education from 2007 to 2010, Professor Barry has extensive experience of coordinating European and international collaborative projects. She has served as advisor to WHO and acted as project leader on major European Union-funded initiatives. Professor Barry has served on a number of international and European steering groups, research councils, and scientific committees, and has acted as an expert advisor on mental health promotion policy and research development in a number of countries around the world. She is co-author of the international text, Implementing Mental Health Promotion, which is currently being revised for a second edition, and she was reappointed in 2016 for a second term to the European Commission Expert Panel on Effective Ways of Investing in Health. Today's presentation has been organized by a number of groups, the National Collaborating Center for the Determinants of Health, so I'd like to thank Connie and her team for organizing and bringing Professor Barry to St. FX. Chris Gillam in our Education Department, thank you, Chris, for your involvement in this. And I'd also like to thank the Ireland-Canada University Foundation for their support and involvement in bringing Professor Barry to Nova Scotia, and we're delighted to have you here today. So with that introduction, I'm turning it over to you. Thank you.
Thank you very much indeed, and I'm really delighted to be here. It's a pleasure. Thank you all for coming this afternoon, and to everybody who's tuning in online. As Dr. Isner said, my presentation today is supported by the Ireland-Canada University Foundation, and that's to try and establish collaborative links between universities in Ireland. So it's good to see the other side of the Atlantic. And it's not my first trip to Canada, but it is my first visit to Nova Scotia. And I want to thank Connie, Clement and her team, Diane and all, for setting up and making me feel so welcome. It's been great, and also to the university here and to the Office of the Associate Vice President of Research for making this talk. Okay, so I'll kick off. There's quite a bit of text on the slides, but I'm happy to make those slides available afterwards. And I hope everybody who's tuning in online can see them, but if not, we'll try and rectify things afterwards to make sure everybody gets a copy. In the talk, I'm going to sort of break it up into three sections. I'm going to start, I think, by looking at current policy and practice frameworks for promoting population mental health. The projection is at the end of the room. I don't mind if you turn your back, so you can see it. It's okay. Provide an overview of current policy and practice frameworks for promoting population mental health and well-being. I want to look specifically at, what does it mean in practice to implement a mental health in all policies approach, which a lot of the policy frameworks are emphasising. And then in the third section, to go and look at some of the evidence-based strategies for effective action across whole of government and across whole of society. And then I'm just going to wrap up a little bit by looking at, well, what capacity is needed to deliver on that, because that's quite a challenging agenda. So firstly, in terms of promoting population mental health, there's much increased recognition now globally that when we promote good mental health, that it does lead to lasting benefits, not only for improved health, but also for social functioning of individuals, of families and of society. And I think that is being recognised. We've also seen over the last 30 years that there has been a concerted effort to build up the evidence to show that this does make a difference. And so there is now quite a robust body of evidence to show that when we promote good mental health, we reduce the risk factors for mental health problems and mental disorders. But we also enhance protective factors for good mental health and health generally, and that's quite important. And we have an increasing evidence base now showing that when we do that, it also leads to positive effects on a range of other outcomes, including academic performance, including employment and social well-being. So in other words, we have quite a convincing social case and an economic case for investing in population mental health and well-being. So just to go back to first principles, what are we talking about when we talk about mental health promotion? We're talking about promoting positive mental health and enhancing social and emotional well-being across the lifespan. It's for everybody. Okay, it's universal. Mental health is still frequently seen as a negative concept, but mental health, if we look at the emphasis on health, is a positive concept and a positive resource. And it's a positive resource for positive life outcomes. So the WHO slogan, "There is no health without mental health," speaks to that. We also know very clearly that the early years lay the foundation for good mental health across the life cycle. So this is a particularly important, it's not the only important period, but it's a particularly important one. And in health promotion, we always ask the question, where is health created? And mental health, like the rest of health, is created where we live our lives. So it's not in hospitals, it's not in clinics. It's in our homes, in our schools, in our communities and in our workplace. And that's where mental health is created, and it's also, I guess, where mental health is damaged. So these are the key settings. So in looking at this, I think a mental health promotion approach broadens and expands our concept of what mental health is, what constitutes good mental health, and how it can be promoted. Looking at the classic definitions, I'm familiar with the WHO definition here of mental health, which says it's a state of emotional and social well-being, in which the individual can realise his or her own abilities, can manage the normal stresses of life, because life isn't all about joy, it's about surviving pain and disappointment as much as anything else, and working effectively and playing a part in one's community. And I'm pleased to see, since I trained in psychology many years ago, that there has been a renewed interest in the concept of positive mental health, because mental health was invariably, I started out as a lecturer in psychology, and I was the lecturer in abnormal psychology, which made me the abnormal psychology lecturer. So that was not a good term to use, and the first thing I was to do was to change the title of what I taught. So we've seen that the literature has expanded. There's a renewed interest now in exploring what we mean by positive mental health. And this includes a sense of subjective well-being and life satisfaction, as well as a sense of positive functioning, engagement and social well-being. So it's the two elements, how we feel within ourselves, but how we relate to our world and the external world around us. And I think Corey Key's concept of flourishing is a good one in capturing that sense of growing to the best of that you can. And it's been incorporated into the titles of a number of policies, like Scotland have Towards a Flourishing Scotland as part, and I think here in Canada it was on some of the policy documents as well. And it's about our abilities to develop psychologically, physically, emotionally, intellectually, socially and spiritually. So it's that wellness kind of continuum in a holistic way. This is an interesting report that was commissioned by the W. Henkin Foundation in 2014, and Professor Michael Marmot and his team in London produced the work on this. And he was looking at the social determinants of mental health. And one of the key messages from that report is that mental health and many of the common mental disorders are shaped to a great extent by the social, economic and physical environments in which people live. And that's quite an important key message, because I think for a long time mental health has been individualised. It has been seen as being within the psychology of the individual, which is part of it, but it's only part of the story. So it's clearly saying the broader environment is hugely influential in determining mental health. And in terms of then responding and addressing the social determinants of mental health, it calls for actions to improve the conditions of daily life, because that's where mental health is created. Okay? And in that document, they clearly endorsed to do this properly, you have to have a whole of government approach and a whole of society approach. And that means comprehensive and universal actions across the life course, multiple sectors involved and at all levels. So it means that policy making at all levels of governance and across sectors, not just the health sector, can make a hugely positive difference to mental health and to mental health outcomes. Therefore, if we want to address the social determinants of mental health, our frameworks for mental health promotion need to operate at these multiple levels. So strengthening individuals and families, ensuring that we have the social and emotional skills development and resilience and coping, sense of control. Strengthening communities to enhance social support, connectedness, social inclusion, strong sense of belonging and social participation. Reorienting our health services so that they are concerned with promotion and prevention alongside treatment and rehabilitation, and mainstreaming promotion and prevention as part of standard delivery, and removing structural barriers to mental health at a societal level, be those structural barriers cultural, economic and our social policies, because these have a hugely influential effect. So that is where the mental health in all policies approach comes logically when we look at that framework. Now, going back to first principles, if we look at the health promotion model and the Ottawa Charter, this is a socio-ecological model, and it clearly says that if we want to look at mental health, we have to look at the individual from a systems perspective, in the context of their family, their community, their environment, and the policies that structure and influence that environment. So if we want to promote mental health, then we need actions at each of those 5 levels. At the individual level in terms of developing skills, at the community level in strengthening community action, reorienting our health services, creating supportive environments for mental health, and lastly, building healthy public policy that will create the conditions for good mental health. So that is the fundamental health promotion model, underpinned by clear principles of participation, empowerment, equity and social justice. So they cut through it. So it sits very well that we have to have that multi-level approach if we want to enable people to increase control over their mental health and the determinants of mental health. The other model, if we look at, is where does this sit within the service continuum? And this figure here, the upper half of the circle, was put forward by Mazik and Haggerty in the 90s as part of the Institute of Medicine report in the US. And that was positioning prevention in relation to treatment and in relation to rehabilitation or maintenance. And you can see there that you can see universal, selective and indicated prevention coming before case identification and treatment, and then followed up by long-term care, aftercare, recovery. So in 2001 I decided we need to put promotion into this and make it into a circle, because it is actually the bigger part. It might be the bit under the waterline, but it's the big part. And that is looking at how do we promote the good mental health of people and keep people mentally healthy. And so here, that is, I added on the bottom half of the circle to say it's about empowering people, it's about increasing competencies, resilience and supportive environments for mental health. And clearly you can see that there is commonality between the mental health promotion and primary prevention, although prevention is always about preventing disorders, promotion is always about promoting health. And you can see that there's a continuity, because as people move through treatment into recovery, they come back into and they need to be maintain their mental health all the way through. So that is where it fits within the spectrum of promotion, prevention, treatment and maintenance. Okay. So looking now to the current policy frameworks, the WHO Global Mental Health Action Plan for 2013 to 20 again reiterates the fact that mental health is essential to achieving health for all. And I think the reason they have to keep saying this is because it has been separated for so long. And we were just chatting outside about mental health and physical health services being quite separate, and mental health being in the shadows, I think, for quite a while. The WHO Action Plan calls for comprehensive strategies, just like I've been talking about, promotion, prevention, treatment and recovery in a whole of government approach. And it talks very clearly about the need to protect and promote the mental well-being of all, so of everybody. And that responsibility extends across all sectors and all government departments. It isn't just the mental health section of the Department of Health, and it isn't just the Department of Health. So it's about mainstreaming mental health, putting it right into the middle in terms of the public health agenda, in terms of our social and economic development agenda, and poverty reduction. That is a central element of all of that. And that's important that the WHO Global Action Plan states that very clearly. The Helsinki Statement on Health in All Policies, which is a WHO document produced in 2013, again was talking about that health in all policies is about systematically taking into account the health implication of all decisions that are made at a policy level. How do they impact health? And looking for synergies, okay, in terms of policies that can improve population health and health equity. So that policymakers are accountable for the health impact of for their policies. And so mental health has to be in there on that. It has to be, we have to look at how do our employment policies, our education policies, housing policies, how do they impact on mental health? More recently, last November, we had the Shanghai Declaration, which talked about health promotion contributing to the Sustainable Development Goals, which are, of course, are replacing the Millennium Development Goals. And health contributes to a lot of those goals, but there is one specifically that talks about ensuring healthy lives and promoting well-being across all ages. That's one of the SDGs, SDG 3. And as part of that, they explicitly talk about the need to promote mental health and well-being, because this contributes. You can't think about kind of sustainable development without looking at the role that health plays in relation to that. So that's actually reinforcing it. So if we take this whole of government approach, I think it takes mental health way beyond that individual framework that it has traditionally been in, and it positions it within a political, economic and social sphere. So it takes it right out into a different space. And so that's what I mean by broadening our understanding of mental health and its determinants. It talks about the fact that governance for mental health and well-being is a priority for more than the mental health sector. It calls for policy coherence, so we can have policies here promoting mental health and policies in another sector undermining. So that you have to look at that cross-sectoral responsibility and the need to address the social determinants of mental health and to reduce inequities. So that's central to all of that. And that clearly calls for intersectoral action and participatory policy processes and very strong leadership to enable it to happen. So these are, perhaps a different suite of skills than would have been traditionally looked for in terms of mental health. When we talk about a whole of society approach, here we're looking at the importance of looking at citizen empowerment, enabling control and agency. So not so much from the policies down, but looking, coming up from communities upwards. And here, if we look at intersectoral action, we have to engage much more widely, across a range of different actors that, again, traditionally may not have been active in the mental health space, across environment, housing, employment, etc. And I see that a lot of the policy documents now refer to mental health and well-being, and some of them refer to mental well-being. And I think the well-being language opens up the door to a much broader set of players than perhaps mental health on its own does. Well-being towards flourishing society, social inclusion, And, you know, so we can see how, if you look at well-being at the local level, the role of arts and culture, of sports, urban design, local communities, local authorities can readily relate to that. So I think that's been an important development there. So it's about the participation of the wider community in creating the conditions that will promote mental health and well-being, right? And that's important because it's creating the conditions that will make that happen. So implementing mental health promotion then, and fundamentally it has to be about implementing, it has to be about delivery, because we can talk, but it has to be about actually doing and making a difference. I think it means working across these sectors to implement actions. And fundamentally, it's about ensuring that there is access to life opportunities and resources that we know contribute to good mental health. And we've got to ensure that that access is that there's equity in terms of that access, be it around supportive relationships, access to good education, employment, income, housing and social inclusion. And as I said, this means intersectoral policies, because if you want good education and it has to be accessible, well then the education sector has a key role to play in terms of that. And this extends the focus way beyond strengthening individual resiliency. It's a much broader framework than that, a much broader social model. Okay, so moving on then to say, well look, if we're going to we know about what works, right? What's going to make the difference if we're going to try and implement this approach? And here's the classic thing of looking at, well, what evidence, what's the best evidence we have to guide priority actions? Like, we're just going to prioritise areas, where should we focus our energies and our investment? Looking at what's effective, what's cost effective and what's feasible. That's really important, like what's going to work in the local context. For whom? The equity impact of interventions. Is it going to work equally well for all? Do we know that? Do we have the evidence to support it? We also need to know more about how it works, right? What is needed to put these actions in place? What training, what skills are required? What resources are required? What organisational capacity is required to support it? And we need to know, will it work in every context? What's the ecological validity of this? You know, we take evidence-informed programmes. If we take them from Boston, are they going to work in Galway and Ireland? You know, you need to know, you can't automatically assume that. So we have been working initially trying to bring the evidence together, synthesising evidence and using kind of maybe different approaches. I've just pulled out some of the work that I've been involved with here. Maybe if I just start with the second one there on that systematic review. That's a classic systematic review of the evidence. But the difference was WHO approached me and asked me to do this. They wanted to bring together the evidence from low and middle income countries, because most of the evidence we have are from high income countries. Right? And it's usually, most of the evidence is from high-income English-speaking countries as well, and that's quite notable. So they asked, and so myself and Rachel Jenkins and Vikram Patel and Alicia Clark, we looked at bringing together the evidence from low- and middle-income countries regarding effective mental health promotion action. And then going on to the top, we had that done and published it. The Eastern Mediterranean region, which includes quite an interesting mix of countries. It has the Gulf region, which is high income. It has middle income and it has low income. It includes Afghanistan, Pakistan. It's a very broad region. So they were bringing the ministries of health together to get them to focus on how they could implement the Global Mental Health Action Plan. So they said, we need to put some policy briefs together for these ministers. So we have to really cut down and say, if you're going to prioritise, based on what we know from the international evidence, where would you start? So we started to sort of distill that evidence. And I work quite closely with Inga Peterson from KwaZulu-Natal University in South Africa, because she works a lot in low resource settings to try and pull that together and pull out what would be the best to use. The third one on the list there is quite different. It's for a health region in France, high-income country, looking at reviewing the evidence. But for there, what they wanted it was for practitioners. So they wanted practice briefs, not policy, So it's a different audience. Like we renewed the evidence, obviously. So we're working off the same set of data, but looking at how you can try and present it for different populations. I've also included there a large gathering of evidence on mental health promotion that was done at the European level. That's classic systematic reviews that have been published, but it's a good resource to delve into. They've done reviews of reviews and really pulled it together. And I mentioned previously that we're currently working on a second edition of the book on implementing mental health promotion. And the reason we actually put this together in the first place, myself and Rachel Jenkins, was to pull out the implementation piece, because you don't read about that in the journals. And we actually asked many of the developers of some of the best programs that have been running to tell us their story about why it works, what makes it work. These are programs that are replicated across countries, and to really look at the implementation element, not just reporting the outcomes. So hopefully that should be ready next year if we do our work well this year. Another piece of work that we did, which is again a slightly different approach to reviewing the evidence. This was commissioned by the Early Intervention Foundation in the UK in London and the UK Cabinet Office, so the Prime Minister's Office. And they wanted to know about social and emotional skills development during childhood and adolescence. And so it was looking at in schools and out of schools. And we did look at the peer review literature about any evidence from the UK. It had to be UK-based evidence. But we also went to the youth organisations to ask them about what are they implementing in this area and what evidence do they have for what they're doing. So it's a slightly different approach, because it was kind of going to what was happening on the ground. And again, that was kind of interesting in that the schools-based evidence is much stronger because it's much stronger internationally. But there was a lot of, and they have a very good structure in the UK for school-based programmes. There were a lot of discrete programmes being brought in and being implemented, but actually not being evaluated in the local context. So there was an assumption that they were working well because they were evidence-based programmes elsewhere. In the out-of-school area, the evidence base was much less well developed because it's a different approach. It doesn't lend itself as easily to RCTs and the classic evaluation. But also what was happening, there was very innovative approaches, but they were being scaled up at national level, but there wasn't any evidence to back them up. And that's dangerous, because there's a belief in these programs, and I believe that a lot of them are probably very effective. But if you have poor quality research, you could ultimately damage the sustainability of those programs. So we recently published a paper on this, just bringing out those points about why, that evidence is really important to support investment in these programs, because you're not doing a good service by leaving them go and not showing that they're doing what they're supposed to do. And so we published that in Adolescent Research Review there just last month. So just going back for a second to that work we did with the Eastern Mediterranean region. This next, we wanted to look at the priority actions, or what they were calling the best buys. And we use this ACE prevention grading system, where you look at the evidence and you say, is there evidence of its cost effectiveness? Is there evidence of feasibility? And is there evidence that it could actually work, in a high income setting and a low income setting? In terms of the resources that might be required to make it work and across the lifespan. Now, this is quite a large table, and you're not meant to read everything that's in it. But basically, we looked at the different platforms, and you can see there on the left, we looked at legislation and regulation. So, for example, evidence around, if you looked at workplace health and safety, and that the health dimension is expanded to include psychosocial health. So discrimination, bullying, harassment in the workplace, that being included as part of, and it is now within the EU regulation. So it puts an emphasis immediately on, mental health in the workplace. The same around, there's some legislation, regulation around alcohol use, and there's very strong evidence to support that as being quite an effective strategy. We also looked at it, public campaigns around public awareness. Again, the evidence from the low and middle income countries is not as strong here. And then we went down, you see the community platform in workplaces, in schools, in communities, and then we looked at what's effective. Now I'll pull out one or two things to just focus in on in a minute. And the final one was then within the healthcare sector itself. And so for each of those, we looked at is there sufficient evidence from high, middle and low income countries that it works? Have we got any economic evidence to back it up? And have we got evidence around its implementation feasibility? And then we graded them in terms of it's a good buy, it's a best buy, or we don't have the evidence at the moment. Right? And then on the basis of that, you try and look and see where you have the strongest evidence to go forward. Or you can also look and say that this is quite promising and we need to build up the evidence for it. Now, if you look at the mental health of children and young people, because I know the national collaborating centres have produced a wonderful set of documents focusing on this, and I think that's going to be quite an important contribution to advancing this area, not only in Canada, I think, but beyond it. High quality early childhood interventions have quite a strong base of evidence behind them now in terms of home visiting programmes, parenting and family support. And the issue here is integrating social and emotional development as part of the standard antenatal service and postnatal home visiting programmes. So that you look at not only the development of the baby physically and their cognitive development, but their social and emotional development is in there too. And that is delivered by, and that the home visitors who do this job are trained to include that. Then we have preschool education, again, traditionally perhaps looking at school readiness, but now also building in social and emotional development for young children as part of the curriculum within the preschools. And then with the school-based programmes, we have quite a strong body of evidence around what's generally referred to now as social and emotional learning as part of the curriculum, particularly within a whole school approach. Now, I'm just going to pull out a couple of examples from each of these and to just kind of have a look. Now, many of you will be familiar maybe with this programme, the OLDS programme. There's over 30 years of research backing up this programme. And it's an example of what can be achieved when you have high quality home visiting programmes. It looked specifically at low income, at risk, pregnant women with their first child. And it's a very structured approach, strengths-based approach, working with first-time mothers, focusing on the mother, but also the health and well-being of the baby, and it could be extended out. And there's a very strong base of evidence, these big randomised controlled trials following up these children from before they were born to the age 15 and afterwards. And you can see there the impacts of that. I mean, the outcomes. That first one, 79% fewer reports of child abuse or neglect. That's very significant impact. More birth control, the mother doing better, fewer behavioural, alcohol and drug abuse problems, criminal arrests, the children doing better in school, and they themselves having less health and social problems. So there's a lot of positive outcomes from that. And usually when I present this, people say, well, that's fine, but can we afford these kind of intensive programs? So the costs of the program were reckoned to be just over $3,000 US developed, but they have done various analyses on this, and these costs are recovered by the child's fourth birthday. So the investment that's gone in has returned because there's reduced need for services. By the time that the kids are age 15, you've got 4 times return. And then the latest estimates is that obviously as you go older, you've got more return on it. So it's a strong investment from every respect. And these are, I think, if you look at it, these are children that their trajectory would have not looked promising. Okay, and now what we're seeing is those kind of programs, they've been replicated across countries, across different populations and groups, and they're being integrated now into standard delivery. Right? So we have it, for example, in the UK, they have it as part of the Sure Start programme. It's delivered to everybody living in a region. And when we looked at the reviewing of the evidence, we also have examples of these types of programs being delivered by non-professionals like community mothers. These are just women who have brought up their own families who work with home visitors. They've done randomised controlled trials on this. They've also done trials with members of the travelling community, like nomadic communities. They're getting equally good results. These are very cost-effective, highly initiatives. I could talk about many others, the triple P, positive parenting is another example, the incredible years. These are all, and what we can get from these are the strategies and approaches that can be taken into the standard delivery. Looking at the preschool, again, the long-term benefits of preschool interventions is fairly now well established, especially for children living in poverty. There's good, strong evidence to support this. The one that's often cited is the high-scope preschool, and I think it's cited because it has followed 3 to 4-year-old children, again coming from quite challenging backgrounds, and they follow them up to the age of 45. So we don't have a lot of research that does that. And here it looks at the impact that good quality preschool can have into adulthood. And it's a very structured, very attractive, active learning model, good connection into the home environment, good parental involvement. So the children, age 45, they've done better in school. They're more likely to complete school. They're more likely to be in employment, to have their own children. And again, the cost-benefit analysis on these programs is a return of $17 for every dollar invested. So, where's the argument about not doing this? There's a big opportunity cost in not investing in these areas. Head Start Ready has incorporated elements of the High Scope project, and as I said, the Sure Start centres are these are regional delivery. So it's universal plus targeted integrated. Yes, that's really quite a good model. Now, finally, just in relation to the schools-based, we have the focus on social and emotional learning. And this is, the literature now is building academic success on social and emotional learning, because there's an understanding that if children are not emotionally present in the classroom, they're not in a position to learn. So this is really strong. I recently did a workshop with all of the school inspectors in Ireland, and I went in with a little bit, I wasn't quite sure how the focus on social and emotional learning would go down. They were absolutely there, and they were hugely positive about that this was so important to bring this into the core business of the classroom and of education. So CASEL in the US have done a huge amount of work highlighting what are, when we talk about social and emotional learning, what are the core competencies and skills that are required? And you can see them there. I mean, self-awareness, how to manage emotions, how to show empathy and appreciate diversity, awareness of others, communicate effectively, act ethically, appropriate social norms and respect. I mean, if we all learned that in school, we'd have a very different world, I suspect. So this is you can see that these really are essential skills for life. And to back it up, there's a good body of evidence. We have meta-analysis, loads to show that if children who receive social and emotional learning programs in a continuous fashion, that they not only enhance their social and emotional skills, but they do better in school, they have more positive social behaviours, they have reduced conduct problems and reduced emotional distress. Now, even teachers are interested in this. They want kids who are positive and are there in class, that they don't spend most of their time managing behaviours rather than teaching. And in terms of educational outcomes, that they achieve academically much better, up to an 11 percentile higher on standard reading and maths tests. That's a very important piece of evidence for the education system, because that is core business. And if we can show that social and emotional learning contributes to better academic performance, well then, there's a good reason to have this, to integrate it and to make sure it's there. But we do need to show that it's not just something that's taught for 30 minutes as in the week. It has to be within a whole school, and that's what the evidence is also endorsing, a whole school approach. So it's not only the content of what's taught, but it's the context within which it's taught, and also that there is the capacity there to deliver on it. And I think in this area also we've had a kind of plethora of individual programs, but I see a movement now to move away from discrete programs to look at common elements across these programs and embed them into everyday practices. And when we do that, I think we'll get much more sustainable change. Yeah? Okay. Now, I'm going to keep an eye on time. I've put this one, the online technologies, and this area, I put it down here because I think the evidence is promising rather than convincing at the moment, but it is a virtual setting for young people. And I think we cannot ignore this. This is where young people use the social media, online technologies. We collaborated with a team in Australia, the Young and Well Cooperative Research Centre on a research programme to look at this. And we reviewed the evidence about online interventions. There's quite a bit on online interventions for depression, like students who have depression or have anxiety, but we wanted to look at its capacity for promotion and prevention. And there's some evidence. It's not as convincing, but it's growing, I think. And for sure, this is where young people are. This is one of their mediums, you know. And like, if we want to reach young people, then you need to be where they are. And so we looked at online gaming, mobile phone interventions, blogging, and online support. And there is promising evidence, but what we have found is that on the online interventions, there's a big dropout rate. And unfortunately, it's often the young people who are most vulnerable who are dropping out earlier. So when these are delivered, they need to be delivered with some face-to-face support as well. This is coming through quite clear now from what we're looking at. And I have a PhD student, Tuli Kuzmanen, and she's been working with young people who've dropped out of mainstream education. They have a lot of complex issues going on, and they're in alternative education settings. And she's been working with them with this gaming intervention, Sparks R, that was developed in New Zealand by Teresa Fleming, Sally Murray and group, and looking at why are kids dropping out? Like, why are we losing them? You know, especially the ones who could benefit the most, like halfway through. So she has just recently been sort of publishing some work on that. The other side of it as well that we looked at was the kind of digital divide, in that young people are very comfortable with this, but often the teachers and the health professionals are not as comfortable. So if they want to support young people to use these interventions effectively, they need to, you know, get with it as well. You know, and so we were looking at that and looking at their views about how it could be incorporated into primary care, how it could be incorporated into just, you know, regular school education, etc. And so that's quite an area I think that there's a lot more to do. So we have a lot of evidence. It's quite a robust case for action, but we do need policy support to back this up, because I think discrete programs will not shift things. These actions have to be embedded. They have to be integrated, and that requires that policy level support to make it possible. And so therefore, that the embedding and the integration of mental health promotion into these other policy areas is absolutely crucial. I'm just going to take a quick check now, because I don't want to go on much beyond 1:15. So, who needs to be engaged for effective action? So these are just some questions, like what is needed to mobilise a public demand for population mental health promotion? Everybody says this is important. I don't think there's anybody who says their mental health is not important to them. But it's not high on the public agenda. I was working with colleagues in Croatia recently, and they had done a review of the political manifestos to see how many of them had included anything about mental health, and they couldn't find anything. So it's not on the political agenda. And if it was on the public agenda, it would be on the political agenda. Do you know what I mean? So it would drive the demand for it. What are the barriers to more active engagement on promoting population mental health? Do we need to change the language? Is the language of mental health and well-being, is it enough to pull people in, to know what is meant? And how to engage people in a much more participatory manner, especially those who are harder to reach. In terms of communities, who needs to be involved to advocate for and create change? Because it's not all going to happen at the policy level. It needs to have a reality in the local context as well. Are new skills and capacity needed? Are new partnerships required? And are innovative policies and intervention needed? So I'm just going to finish with a couple of slides to sort of speak to this, and then we'll open it up. But I'd like to hear your comments on these kind of questions, because these are some of the things that came to me as I was, in looking at it. Unlocking the potential in other sectors. How do we do that? How do we make them as concerned about impact on health and mental health? when they are doing their business? How do we negotiate and speak to their agendas? Okay. In terms of the wider community, I think, how do we create a better public understanding of positive mental health? Because I think mental health is still very much seen as a negative concept. Yeah? And bringing an explicit focus on emotional and social well-being and how social values, culture and public policies impact on our understanding of that. And I think here there's a lot of emphasis on health literacy and mental health literacy. And I think we need to broaden this. It's broader than just being able to recognise, even though it's important to be able to recognise mental health symptoms and problems. But it's also very important to know, how do you look after your own mental health? How do you protect that? How do you promote that? Every day. So that broader mental health literacy, and of course that is in the context not only of individuals, but it's cultural, educational and social processes that influence that. And the extent to which the organisations we interact with are mental health literate. You know, so people who are in the welfare system, the way they're treated, how does that impact, etc., when we interact with other sectors. So I think that will be important in mobilising a demand for a more mentally healthy society. It'll require capacity development in terms of policy and implementation. And I'm just going to go quickly now to get this. In terms of policies, I think we need policies that will enable much more action at a public level, not just at an individual level. And that shift has to happen. Coordinated multi-sectoral policy development that we just talked about, scaling up and integrating this as part of, you know, your cross-sectoral planning and delivery. With regard to effective implementation, we have a growing body of implementation science, but I think in terms of mental health promotion and health promotion more generally, I think we're just at first base on this. We need to know a lot more about the delivery end. You know, we have the evidence about the outcome, about much more effective implementation practice. And practice-based evidence to integrate that. And that is, you know, it's been talked about for a while, but I don't see it advancing a huge amount. And we may need new research paradigms, because if you look at our evaluation, traditional evaluation research is very much about linear processes. You do X and you get Y. What about the bit in the middle? What about systems change? And I think we need to look at other disciplines, transdisciplinary research that work with systems change to understand how we could develop new methodologies on that. The implementation infrastructure, I think, in a lot of countries is not there for population mental health promotion. You know, it's on the policies, but there is no implementation infrastructure to really make sure this goes into standard services and supports and different policies. So the delivery mechanisms are not developed. And that has to be taught through. And the organisational capacity has to be there to support it. Because it won't happen by itself, no matter how much we argue for it. And this is my final slide here. I strongly believe that we have to strengthen the leadership and workforce development in mental health. I travel to a lot of different countries, and often when we're talking about mental health promotion, I say, well, whose responsibility is it to make this happen? Who's going to look after implementation? Who are going to be the catalysts for change? It doesn't mean they have to do everything, but they've got to bring the partners together. They've got to make sure they're talking across sectors. And this requires a different suite of skills. And I think public health specialists are more comfortable working across sectors. They're more comfortable talking to social change. Mental health specialists traditionally are not. And I read a lovely article from the American Psychiatric Association actually talking about this. When we look at mental health specialists, they're very comfortable with mental health, but they're not very comfortable perhaps with intersectoral action or talking at a kind of social change level. And the public health folk may not be comfortable with mental health. So we have to bridge that divide, because we need that mix of skills. And, you know, the training on mental health is very minuscule when it comes to public health. So these have to be bridged. And the practice skills that are required for partnership working and effective partnership working, and skills of advocacy and leadership. And just briefly, we looked at this. The WHO asked us to, for the health in all policies, to look at intersectoral partnerships, and we looked at trying to review what are effective processes, and I worked with Hope Corbin and Jackie Jones on this, and we could find that there were effective processes which are important in terms of a shared agenda, boundary spanning, good communication, and Jackie's work particularly said trust was incredibly important. There's no way you're going to get synergy if you don't have trust among the partners. And the startling thing that about 50% of partnerships don't work. So there's very little research. We can get the research on the effective process, but linking it to effective outcomes. So again, there's a lot more we need to know about how to do this properly, because you can get folk around the table, but what are you going to do with them once you've got them there? To really make it work. So these are the skills of intersectoral working and effective partnerships. So we need the systems, we need the structures to support action, we need the science and research to support this, but we also need very good practice skills to deliver. And these have to really work together, I think, if we want sustainable action and change for population mental health. So I'm going to stop now. And I'll leave you with a picture from Ireland and the west of Ireland. Okay, and I'm happy to take any questions or comments people have. So thank you very much for listening.
We have no questions from live stream yet.
Okay.
So the room has control right now.
Right. Okay.
Thank you very much for this presentation. It's exciting. I would like to know that how actually you considered the perspective of new program review and future planning, the gender perspective, because I've seen the school programs, the education institute. So how you consider the situation of gender, transgender?
Margaret, could you maybe repeat the question just in case our live stream?
Okay, so the question was in relation to when we're doing the evidence reviews, how we consider the issue of gender and LGBT issues in terms of, for example, when we looked at the evidence review for the UK, the Cabinet Office, what works, that review, one of the things I looked at was there evidence around equity impact? And in fact, there's very limited evidence. Even down in terms of does it work better for males than females? So the issue of and looking at different subpopulation groups, the evidence was very poorly developed on that. I did see a review produced by the National Children's Bureau in the UK in relation to gender issues and mental health, which was a 2016 review. But the equity impact of a lot of these interventions is poorly developed. What we do know is that in most, like for example from the early years interventions, in most cases, those families, for example, that are most vulnerable benefit the most. When we come into schools programs, the equity impact is not strongly established. And we need to look at that more longitudinally. It may work, if you look at a 12-month follow-up, but in terms of the lifetime impact of that, does it outweigh other factors? So that is not well developed. Yes.
I really found your stats about the for every dollar you invest, you get 17 back. And it's very powerful. And I'm wondering along those lines, from your reviews, have you come across like low-hanging fruit or examples that it's just right there, waiting for us to grab and use up to get that $17 benefit?
But I think, yes. The question was in relation to some of the return on investment from some of these programs, like for every dollar invested, you get a $17 return. And then, examples of low-hanging fruit. I think they are examples. I mean, investment in the early years is a no-brainer, really. I mean, I've yet to see someone who would argue against this credibly, investment in the early year. But I mean, this is very specifically saying that if you incorporate a focus, and actually I didn't mention it, but it was on my slides, the OECD had a report in 2015 on skills for social progress. And I mean, they're interested in economic and development, social progress. And in that report, they focused very clearly on the development of social and emotional skills for young people as being absolutely critical to social progress.
So beyond children and youth, to sort of put them aside, what would be other low-hanging, should we put all our eggs in that youth and child development basket?
No.
Is that where the return is, really? Or are there other opportunities for seniors, for example?
Yeah. So again, the question related to whether we should focus only on the early years and young people, or are there other opportunities across the population? And I think you'd agree with me in saying, of course there is. What I would say is that in terms of the evidence base, if you look at once you get over 18 or 20, it's less well developed, and it's shockingly underdeveloped when it comes to older people. Yeah, I mean, there are some examples of some very good interventions, and also it's shockingly underdeveloped when you look at upstream interventions like urban regeneration and its impact on mental health, the impact of poor housing on people's mental health, and when you improve that. And I think it's partly because that when these initiatives are evaluated, nobody is considering the mental health and well-being impact. Yeah, it's just not being built in. So it's something about making sure that, it's like that mental health in all policies. You have to ensure that it's in there as part of the evaluations. But I mean, there is massive scope across the board. A lot of emphasis now in Europe, certainly around workplace for adults, and looking at creating healthy workplaces and mental health, particularly within the workplace. And again, there are some kind of, research looking at the return on investment in relation to lower absenteeism, increased productivity, not to mention, mentally healthier workers who feel more content. And of course, there's a big sort of ripple effect from that out into families, etc. So the workplace is starting to be focused as well as beyond. Yeah.
I have been calling for questions from online, and we apparently have good mics in this room, so they're picking up everything.
Great. So happy to take any questions from online if they have any.
Yep, there's none yet.
Okay, English.
In the word of public health, I start to talk more about eco-social determinants of health. Mm-hmm. The idea is that the person or people are one component of what makes a healthy environment and the ecosystem, the way people live in balance with the natural environment, plants and animals is very important. We're also learning that people being out in nature is very important, and access to good clean environments is essential. And yet I find it's a struggle because there's certainly where I'm living now, there's a growing awareness among communities about how it is important to have some determination about things that go on in the communities, try to have some input into the communities to make them as healthy or at least to try and influence decisions that are made over the communities. And I think when you talk about the whole of government approach, I agree it's essential. But on one hand, governments sometimes say, well, yes, we want to put more money into mental health, and it still is viewed as very much a treatment model.
Yeah.
And yet they don't really want to enable or empower the communities because those people are activists or environmentalists associated with it. So how do you get across that divide of accepting that it actually is good and positive to have people contributing and wanting to develop to their community development and pushing them down?
Yeah. I think that tension is always there. I mean, while you'll talk about a whole of government and a whole of society, often the two of them don't meet. You know what I mean? When you're looking at a policy-driven approach that comes down, there are some examples of where engagement in local government planning by local communities, where the influence there in terms of what's prioritised to happen, what's important to that community, what gets higher up on the agenda. And so, where there is some meeting of the two. But I think that's an inevitable tension that's there. I think in terms of, if you look at that model, between a kind of control and an influence. I've no ready answer to it, I'm afraid, but I'm aware of what you're talking about for sure.
Margaret, we do have one question.
Yes.
Live stream. So this comes from a friend of ours in Peel region in Ontario, which is just outside of Toronto. Oh no, it doesn't. It comes from Marcy McKay, who's a health promoter with Nova Scotia Health. And Marcy's wondering about, are there any examples of countries or regions that have used a whole school approach to social emotional learning, and where we could look into it to learn more?
Yeah. Well, the whole school approach is very close to the Health Promoting Schools initiative, right? And so there are, in countries, the Health Promoting Schools initiative is dominant. Now, I talked about in the UK. The UK, as part of their curriculum, they have the SEAL, Social and Emotional Learning Framework. In Ireland, we have, in our curriculum since 2000, we have legislation to support the teaching of social and personal and health education as part of the curriculum. It's a compulsory part of the curriculum. Now, those two, I know both those countries better, but even with that, even with legislation supporting it, and even with SEAL has a massive suite of resources that were developed to really support social and emotional learning. The reality on the ground is that often this gets sidelined, right? And if you run out of space in the timetable, that will be the first one to get squeezed. And the reality on the ground is often that the youngest teacher in gets that job to do. So, even when you have that, but there are, I would say Finland at the moment is actually very much trying to progress a health promoting school, whole of school approach. They have a massive initiative underway at government level. I haven't seen, I know it's underway, but I haven't seen any of the written stuff coming out about how it's doing, but I know that they're certainly, and of course Finland is the home of the health in all policies approach, so it's not surprising that it's there.
Do you have a name for that program?
No, it's not a program, it's actually part of their educational kind of reform, if you like.
Okay.
But I'll try and find a contact name, maybe.
Sure.
Yeah, that people could get in touch with. Yeah.
Maybe an answer to the question, you know this, but the Public Health Agency of Canada supports the Joint Consortium for the Promotion of Positive Mental Health in Schools.
That's right, yeah.
So that might be the direction that person.
And there's also,
evidence is for that.
but the Well Ahead initiative. Are you familiar with that? No, that's another one here in Canada, which is being promoted by, I think there are two philanthropic foundations who are working with schools. It's pan-Canadian, but it's particularly in British Columbia. And of course, Cassell in the US, particularly in Illinois, they have, all of that stuff has been actually, implemented in the schools there. So they have a massive resource there. Yeah.
Live stream. So this one comes from Wendy Dobson, who's a research and policy analyst at Peel Health, so that's outside of Toronto. And Wendy is wondering, how do you link social emotional learning with general mental health, when mental health is often the working definition of the language that's in policy frameworks? So how do you sort of switch it?
Yeah. Well, if you look at the definition of mental health, it says mental health is a state of social and emotional well-being. So that's how I stitch it. And if you look at good mental health, it's about social and emotional skills development. But, I think she's touching on an important point here, which is the point about language.
Yes.
It's, and that's why I think in terms of school, social and emotional learning, I think it works better. I think when we come to workplace, there may be a different language used. But to answer her question directly, I think the definitions of mental health are about social and emotional well-being. And of course the other elements, it's not separated out. Yeah. Yeah.
I think what makes this interesting is that there are many powerful organizations and professionals, psychiatry being one of them, where there are competing definitions of mental health, well-being, and flourishing. And they're all trying to stake their ground around which one should be the
Yeah. Yeah.
And I wonder if what we say when we actually say mental health, what we hear is mental illness.
Yeah, I
I
think,
think that's key.
yeah, yeah, yeah.
And when we talk about mental health in terms of, you know, what has to happen, because I really do believe that mental health is just going to bring this world to its knees. If we don't figure out
Yeah.
a way to do this.
Yeah, yeah,
Because
yeah,
that's what's happening.
yeah. And so, yeah, go on, Connie.
Mental illness.
Mental
Well, mental illness will get us off our knees. And that happens with health in general. You have good data for Canada. Then when you say health, Canadians think disease and medicine.
Because of how the medical model has been
Yeah,
so huge.
yeah, yeah.
The model is so ingrained
yeah.
in worldview. It's across all.
And also, there's an issue, like there's a big discussion. Do you keep mental health and reframe it? Do you keep health and reframe it? Or do you start over? So anyway, that's another, yes, you wanted to.
I just was going to say that this is all part of the mental health literacy.
Yeah.
And the need for the conversations to get to the conflicts in some of the language.
Yeah, yeah. No, the language, I think the language can be a barrier. You know, and as you said, there are definitions competing, you know, there's lots of players competing for turf, if you like. I mean, which seems ridiculous, but yeah. And you know, I mean, I think I'd be less, in some respects, less concerned about what it's called and more concerned about what's actually done. Do you know what I mean? If we can focus on what are the actions that are actually going to make a difference? And then whatever enables that to get on the agenda and to happen, which may be different for different audiences, you know? That's a pragmatic approach, I guess. Yeah. Yes?
So I've been involved in social emotional learning for probably 25 years here in Canada, different aspects of my life.
Right.
So right now I'm here at the University of Safety and Security capacity. And I come at it as an educator, not as a law enforcement officer. So the approach that I'm concerned about is what we're seeing here at the university level is a crisis. We're seeing the inability for young people, they don't have the coping skills to deal with adversity. So my background, I spent 5 years with public health services doing some work there and in school health and things like that. So my interest is, you know, we've seen the maturation process bump up a few years. So we used to see people maturing in grade 9, 10, 11. They're now first, second, third year. So because it's still late, right? Because of the parental influences and snowplow parenting and all that kind of stuff. So the concern I have is about language. And I'm very much, knowing the work that Doris done around health literacy for years, and it is a literacy issue. And what we're doing, though, to parents and developing persons is we have health language, we have educational language, we have justice language, academic language, and we're really talking about human growth and development. And what we're not doing the job, and on this campus, there's a lot of LGBTQ kind of, we got diversity over here, we got equity, and all good, right? But we're losing sight of treating each other as persons, okay, and talking about the growth and development of human beings and their well-being and things like that. So because parents, can't pay attention, especially anyone that's disadvantaged from an income or an education level, they can't pay attention to the 10 things that health wants you to pay attention to, or the 15 things education wants you to pay attention to, or the community services or stuff. So, the role we're trying to take within safety and security is we're trying to look at, a kind of a model of, and my counterpart here, Matt Gerard's here with me, we're talking about student life and safety and security coming together on this village, okay? So we're doing a little experiment, and talking about fostering community, because I think at the very core, we have society, but we're losing community, and in order to really engage everyone in a wellness, kind of well-being approach, we have to get down to really creating that community of responsibility, and that we're all here to support each other. So fostering that community, being of service to each other, and then being able to lead by example, but being able to do it with a language.
Yeah.
And we've got a lot of international students coming here, so what we're trying to do is make sure the language we're using is accessible. Because, it's going to be mostly English that people are going to converse in. But so I think language is at the core and literacy is at the core, but it has to get about personal, the growth and development of human, and not get too sidetracked. We can boil this ocean forever. Right?
Yeah.
So,
No, I think that's an important point. Thank you.
Margaret, I have one offering from the live stream here. We've got someone online from the Nova Scotia Health Authority who's a health promotion coordinator, and he was just saying around the health promoting schools and social emotional learning. He said the health promoting schools in the Annapolis Valley and on the South Shore of Nova Scotia are doing really well in social emotional learning and whole school.
Great. Yeah.
So also just to offer for people in the room to let them know.
Yeah. And there are good examples. I suppose what we'd like to see is that every school might be it. Do you know what I mean? So if you're lucky enough to live, where they're doing good work and there's good examples, that's great for the kids in those schools. I mean, I suppose the aim is to say, look, can we make this experience for everyone? I think that's the ambition, isn't it? Yeah. Yes, Ken?
Yeah, we can do that. Sure.
I'm just wondering about, maybe to pick up on Ailish's line of questioning that they talk about this thing now called ecological anxiety. And so we're putting this emotional and social well-being in the context of some really profound reasons for anxiety in society. Mental dis-ease might actually be a sane response.
Yeah.
And so I wonder if you have thought at all about that, that...
Yeah, I mean, when you were saying what I was thinking of, mental health is not about the absence of anxiety. It's not about the absence of sadness. I mean, we should be really worried about some things. It's not about that. I mean, that's part of living, but I think what it is about working out how you respond to all of these things and how you make sense of them, and how you're enabled to make decisions for yourself in relation. It's not about the absence, it's not about eternal happiness, regrettably, but it isn't. Yeah, it's not. That's a bit of a short answer, but that's what, when you asked me, that's what I thought. It's not about the absence of depression or anxiety, but but what it is about, I think, is about reducing the risk that becomes quite a chronic and severe and disabling condition that you never come out of. That's what it is about. And it's about developing, I think, the skills and the resources to manage your life as well as you can under the circumstances, and hopefully bring about change. Yes?
I want to ask you about, you mentioned that there's really, that the evidence on implementation and delivery is what I'm interested in, and the practice skills.
Yes.
I wonder what we know about that in context of mental health promotion around all of those settings of, policy, community, capacity. Yeah. What do we know?
I think they've developed a body of knowledge, certainly around the implementation of discrete interventions, around good implementation skills, what makes implementation successful. And if you take evidence-based or evidence-informed approaches, what's needed to make them successful. I'm just thinking like the Blueprints resource. It's an online resource. You can go in and it completely, it lays out it goes into all of the detail about what to do to make this work. Right down to all of the planning, all of the preparation, who needs to be engaged, what training, what skills are required, what resources may be needed. And that's really valuable in terms of just thinking through the nuts and bolts of what's done. Yeah. And you see, if that's not done well, it doesn't matter how much evidence you have. If the implementation isn't done well, you just will not get good outcomes.
So I pick that up to higher level question of the commitment to those kinds of things within systems and the hierarchical nature of health generally, and I'm interested in health practitioners. So if you fail to value or view those as aspects of what is, then you probably don't get to the implementation stage. So I'm thinking of, power in practice really, and how we come to think about our working relationships with people differently, and in a way that really enables them it creates the conditions where they feel like they can exercise more.
That's right. Yeah. And where people who are trying to do things and make a change are given the space and the resources, they're given the time to plan. I mean, I know in our system, if you're fortunate enough to get a budget for something, you're saying, you've got it, but you've got to use it within the next. So there's no time to do the long planning and lead in. And then when you do it and you produce really good results, they can say that's fine, but there's no more funding for that. So then you're on to the next thing. So that's, exactly. Yeah.
So it's about how do we chip away at the medical model? Because the medical model doesn't favor these longer term.
Well, I think it favours them for medical practice. I think it does.
But not
so it could.
When it comes to the kind of practice that you're talking about. These things, there are few rewards for things that take a long time to do.
Yeah, that's right. It is a long-term investment. It is, for sure.
I think people want more
quick return. Yeah, that's right. Yeah. Okay.
Are there any other questions? I think online, our live stream audience is okay, but okay, Connie, did you want to come up?
Okay.
Oh, I lied. I have one last minute live stream. It's Michael Fisher of St. FX there. So Michael wanted to know, have there been any studies and results depicting if and how the school-based mental health programs might impact students from different cultural and socioeconomic.
There is indeed, and I would say those meta-analyses that have been done by Joe Durlak and colleagues from Chicago, there's quite a lot of evidence. Cassell have evidence on that. So yes.
Okay.
Yeah, big reviews of multiple studies showing. Yeah. It's quite convincing, I think. Yeah.
So I wanted to say thank you. We're a few days into 3 weeks, so we're having a great time. But that was articulate, thorough, insightful, helpful. It was marvelous. And I think for me, as I listened, so I'm Connie Clement from the National Collaborating Center for Determinants of Health, located here in Antigonish at St. Francis Xavier. One of 6 public health knowledge centers that try to bring evidence and other kinds of knowledge to public health practice across Canada. But I could really see how what you were saying in terms of determinants of population mental health promotion applied across all the determinants. This is such a both a familiar story and one so well told, and really pulling that range of evidence was great. And I just want to add, I don't know if she's on the phone, but Pascal Mantura from the Center for Healthy Public Policy, who really is our mental health promotion content expert within our 6 knowledge centers, has spoken astoundingly highly of Margaret. And so this week I've had the pleasure of understanding on what basis she has said that over the period. And I do want to name an oversight. That was my oversight. Margaret's last slide should have been promoting a brand new set of resources that the 6 NCCs just did together, and we forgot to ask her to do that. So in May, just not even a month ago, in fact, we released a whole suite of new resources that were built on some needs assessment that Healthy Public Policy did with all of us about the needs of public health in terms of knowledge, skills, concept understanding to move forward population mental health. And we responded as a group by creating a suite of resources that brought each of our individual perspectives, so an environmental or infectious disease or Indigenous perspective, to the question of public health roles, some good examples of work and resources. And they created a database of resources and organizations that would be helpful to public health as well. So we will figure out a way to promote that. Maybe I'll put it out through the faculty list and people can share it with staff as well. And it's certainly on our website and the collaborative website for the NCCs. And I know that in the foundational for document for that suite of products, we use Margaret's work very much. So I just want to say thank you.
You're welcome.
And thank you to the audience.